Hello, everyone, and welcome to the webinar, Montana Healthcare Foundation webinar number 3, Financing Integrated Behavioral Health. My name is Leah Sims. I'm the Policy Assistant for Practice Improvement here at the National Council for Behavioral Health, and I will serve as your moderator this afternoon. Before I begin, I'd like to draw your attention to some important webinar logistics. Today's webinar is being recorded, and you are currently in a listen-only mode. If you're listening on your phone, please enter your telephone keypad in the audio PIN number from the control panel on the right side of your screen. You may send us questions at any time during this webinar. Simply type your question into the dialog box to the right of your screen and send it to the organizer. Depending on the question, we may type an answer back to you, interrupt the speaker to ask it, or save it for the end. We'll answer as many of your questions as time allows. An audio version of the entire webinar and a PDF of the presentation will be emailed to you by the end of the week. Following the webinar, we invite you to please complete a short survey. If at any point during the webinar you experience technical difficulties, please call Citrus Tech Support at 888-259-8414. I'll now pass things off to Jeff. Jeff, are you on the line?
Yes, Leah, I can't see the screen. Do you have the slides up?
Yep, 1 second. Let me just pull them up quickly.
There we go. And welcome, everyone. My name is Jeff Capobianco. I work with the National Council. Recognizing some names in the attendees list here. Good to see you. I still got a blue screen. There we go. So if you've been attending these webinars on sustainability or financing, Verna has done the last two, and she took a deep dive into many of the, oh, we're going to move it over to me, good. Many of the aspects of billing and creating sustainability through making your front door a lot more efficient, through same-day, next-day access. She got into just-in-time prescribing, I believe. Also talked about some different ways to enhance your access to credentialing for your staff, a whole bunch of things. And in today's webinar, we really wanted to take a deep dive into designing an integration program that is sustainable and give you some insights into what we've learned from working with a lot of different agencies that are doing integrated health, both at FQHC, community mental health, and hospital levels. So before I jump into it, just a quick disclosure that this webinar comes to you partially funded by SAMHSA, and the views expressed are not the express views of SAMHSA or the Department of Health and Human Services. So today we're going to touch on value-based purchasing a bit because this is really the context in which we're seeing healthcare move, and Montana is no different, although it might take a little bit longer to get to Montana. It is coming. We're going to talk about designing your strategic organizational plan for your integration project that really is your business plan that is going to set you up for success, and talk about the components of a charter or a charge and that actual work plan that you're going to be rolling out, or that some of you are already rolling out. And then we'll talk about sustaining that change through continuous quality improvement, but also through keeping track of your business metrics as it relates to clinical outcomes and financial outcomes. So that's just an overview. And I really would like people to ask questions as we go through this. We've got almost 40 people on the line here. And if you've got questions as I'm moving along through this, just type them in or raise your hand, and Leah can click on you and open your line. As always, we suggest that you call in. So if you're on your computer and you're using your computer microphone, you can always hang up your computer and call in via the phone. The phone number should be just above your, just about in the middle of the dashboard to your right on this webinar screen. So a focus of healthcare today, which is always should have been the focus, but is now more so, is very much this focus on being both efficient, meaning getting patients into care quickly and billing effectively for services rendered, but you also need to be effective in being able to do it. So the effective piece is the piece that's somewhat new, and this talks about customer satisfaction or customer engagement. This is this notion that we are now going to be responsible for producing the quality outcomes, producing the treat to target metrics that we're setting our patients up for success to obtain. And this is very different than the traditional just being efficient healthcare system where we could bill for a procedure, and if people didn't get better, well, we told them they needed to change their lifestyle and their health behaviors. Now we're going to be held more accountable for that. Integration of healthcare services really is in service of doing just that, making things more efficient and more effective. So creating effectiveness really requires that we look at our care pathways, and care pathways are those journeys we send patients down when they come into our services. We screen them, we provide treatment, then we monitor that treatment to see if they're getting better, and if they do get better, we step them down from care. If they get worse, or if they develop new conditions, we step them up to care. So it's this care pathway that really has to be well designed if we're going to hit those effectiveness targets. The efficiency targets we have speak to billing and speak to making sure that we have staffed up our clinic correctly and that we get access to services for our people that are efficient, so people can come into care pretty quickly, receive the care they need, and start improving their health. So in the former world of fee-for-service or volume-based care, the focus really was just on efficiency. Now with value-based purchasing, we really have to look at being both efficient and effective, which requires us to remap our care pathways and our staff workflows. If we think of care pathways as kind of the clinical guidelines that we use to treat people, and then the workflows, the staff workflows being kind of that back office work where we're billing for things, we're developing policies and procedures, we're doing our paperwork, we're doing population health management where we're, using registries to see if people are getting better or not. Both of those things are in play now with integration and with value-based care. It's a term that's been around for a very long time. This slide speaks to a quote back in the late 90s. So it's something we've always been aware of, something we always strive for, to be both efficient and effective, but it's really in play today in healthcare, and we don't see that changing with the new administration. If anything, we're going to see this ramping up probably a little bit faster. For value-based service implementation and value-based payments, right now, most of Montana is very much still in a fee-for-service or maybe even a cost-based contract where you're going to get blocks of money that you need to spend down, and you have to report a little bit on what you do with it, but essentially it's grant-based. As we move up this pathway, the financial risk becomes greater for the provider, and the integration really needs to happen even more. Accountability becomes greater, but with the financial risk also comes the possibility of possibly making a little more money too. So eventually, as we move for fee-for-service and start to see some incentive payments coming our way, where if we hit some HEDIS targets, we might get an enhanced rate, and eventually, we start to move towards this pay for performance and bundled rates where, we're given a set amount of money for treatment of a specific condition. And if we treat that effectively and efficiently, we can actually make a little money on it. And then we move up into the accountable care designs where we're starting to really see a lot of shared savings and a lot of shared risk that is something we're probably going to see in the next 8 to 10 years. If you've been watching what's happening with Medicare and MACRA, they're looking at 2020 into 2026 as some of the horizons we're really going to see this take hold. And since MACRA was a bipartisan law put in place, we don't see that going away. If anything, Medicaid will probably follow MACRA. So I'm a big proponent of understanding our terms, and as we look at designing sustainable care, it's imperative that everybody in the clinic and everybody in leadership are using the same definitions for these terms that are now in play in healthcare in very big ways. So we've talked about value-based services or value-based payment approaches, and in order to achieve that, you really need to have robust population health management. And population health management is this capacity organizations have to track both individual patients as they receive care, and then also track groups of patients or populations of patients as groups of patients receive care. So it's this ability for us to tailor care as best we can to the individual, track that care, make sure they're getting better, but then to ask questions of the data we have to see, are certain groups getting better than others based on different health conditions. So we know for African American males, they have very high rate of high blood pressure. So we can look at that population, African American males, and say, are we doing a good job with prevention and treatment of high blood pressure? Because we know that's a killer. We know those people are at very high risk of dying from this condition. We can also look at different diagnoses and start to say, how are people doing that are obese? Are people who are obese getting better in our clinic after a year or two of treatment? They should start to see their weight moving in the direction of coming down. If not, what can we do differently about that? So this big data we have through our EHRs, even though many of us are still struggling with them and making them work the way we want them to, allows us to do this population health management. And knowing who's responsible for that in your clinic is really important. So if you have a care coordinator that's overseeing that for a team, or if the supervisor is responsible for that, somebody has to be responsible for population health for a clinic. Each clinician certainly is responsible, but ultimately the buck has to stop with somebody. Somebody has to be watching the care provision and seeing if people are getting better or not. Risk stratification I spoke to when I spoke of, who's getting better, who's getting worse. So who's at risk for getting sicker, who's at risk for getting better, if you want to look at it that way. Risk stratification also requires us to look at money, and that's part of the population health management work. Is not only do we want to look at clinical outcomes and see if people are achieving them, we need to look at whether people we're treating them effectively from the standpoint of billing for them, and are they getting too expensive for us? What are we treating them in a way that's both effective for them to get better, and are we treating them in a way that's efficient for us as a clinic to stay in business? Because giving lots of services to people that don't need them is not the way to stay in business. And giving too few services to people that really need them is not the way to stay in business. So when it comes to risk stratification in our population health management, we really need to be able to know what clinicians are doing what with our clients. Are we doing enough outreaches or too many outreaches? Do we have people going to the emergency room and it's costing the system lots of money? That puts us at risk of being not hitting our targets for all-cause admission. So this risk stratification population health management is a critical part of your business success and your clinical success, and it requires that you thoroughly understand your clinical, your patient engagement or satisfaction, and financial data. Only by doing this are you going to be both efficient and effective. So when we look at how organizations have been able to design an integrated system that is both efficient and effective, and that is sustainable, we have found that the best organizations, the ones that are able to pull this off, use a change management technology in not only implementing something new like integrated health, but they also use it to maintain gains they've made as a business and to maintain metrics that show patients are getting better. Change management at the organization level never really goes away because change really is the only constant we're dealing with in many businesses today, particularly healthcare. So we really encourage organizations to use a change leadership or an organizational change technology to maintain gains and to start new programs. So start up those new programs, and as they get going, maintain those gains by using a technology like the one mentioned on this slide, which is John Carter's work. And most of these organizational change technologies came out of the business world, and they work perfectly well in healthcare. You can pick Carter's work, Lancione's work. There's a whole variety of books out there. We suggest if you're going to put your business model together and you're going to create really impactful change that's sustainable, that the leadership, and the leadership including middle managers and senior managers, pick a change model that resonates with them. Get that book, read it, and all follow it. We like Cotter. He seems to have probably one of the longer research bases around his model. And as you can see here, it's a multi-step process, which starts with, creating urgency within the organization to say, hey, this integrated health stuff is important. We are going to do it. And it's going to bring changes to our organization that are sometimes going to be difficult to implement and other times going to be easy, but we're going to do it. And it requires that the senior leadership really message this clearly. And I'll talk a little bit about messaging in a minute. That you build your teams that are going to implement it, and I'll talk about that. That you get that vision right. Vision really is your reset button. It's the reason why you're doing integration. It's the thing you're always striving for, but you never fully achieve. It's the vision statement you have as an organization. That is a very, very important statement because it's what you're going to bring to staff when things are really tough and say, this is why we're doing it. We have a vision of being integrated in our care delivery because we know it saves lives and it makes things more efficient and effective for us as providers. That you can effectively communicate, step number 4 there, that you can effectively communicate that change to staff and create their buy-in so they actually change their behaviors in the workflows. You make it easy for them by having really clear work plans and clear targets, which I'll talk about, and that you create short-term wins out of the gate where people can start to see, hey, this is actually working. We're actually getting this done. And that you never let up on that urgency. You never let up on the fact that we can always get better to move towards achieving our vision. And once you find a way to do something effectively, number 8, that you make it stick by using continuous quality improvement. We'll talk about this. What does that look like when you're implementing a model like integrated care? So I'm going to go through 5 steps here, and all of them add up to what we've been talking about being efficient and effective in integrating. I'm going to touch on the organization's strategic plan and where does integration fit into that or not. I'm going to talk about effective leadership communication and the need typically for a plan to do that. I'm going to talk about the charter or the charge that you've given your teams or that you will give your teams to get this work done, and then your integrated health work plan, and then the ongoing continuous quality improvement to keep in specification whatever changes you were able to put in place through that work plan. So let's talk about your strategic plan as an organization. If you're a big hospital, I know we've got some hospitals on the line here. If you're a CMH or an FQHC, most of you have a strategic plan, and it's written somewhere. It's given to the board once a year, once every 3 years, and it basically lays out your vision, your mission, and why your organization exists, essentially. Why question being that vision, the what being the mission. Typically mission statements are things you can actually measure. These are statements like, we will provide efficient and effective care, or we will provide services with high satisfaction. Those are things you can measure. Vision typically is something off in the distance you can't really measure well that you're always striving for and never truly achieved, such as world-class healthcare or something like that. This organization strategic plan is really essential for your success in implementing your integration program. And the reason for this is it's what you're going to turn to whenever you hit a rough patch. It's what you're going to turn to when this goes really well. And it's really the framework in which your senior management should have their employee work plan designed around. So it's essential that if you don't have integration somewhere articulated in your strategic plan, or if your senior management can't explain to you where integration fits into the overall strategy of your organization, even if it's a big organization and it's going to fit in one aspect of a very large strategic plan, you're already starting at a very difficult place. So we always encourage teams to make sure they understand where integration fits in with the strategic plan, because the strategic plan is essentially your senior leadership's work plan. It's what keeps them up at night or gets them excited. So you always want to link to that, because ultimately the senior management is the one that's going to make or break implementation of programs, either by supporting them or ignoring them. They're very important in making sure your integration is successful. The strategic plan typically has some metrics assigned to it, but we always encourage that your senior leadership have some dashboard metrics and that integration fits into those dashboard metrics. Whether it's cost, looking at if you're hiring a behaviorist to work in the primary care clinic, that that behaviorist is sustainable after grant funding runs out so that they can bill for themselves, or that you have metrics in that senior leadership top-level plan around hitting targets for HEDIS measures. Whatever it might be, you want to link your integrated plan to those metrics, because it really helps you be able to define if you're successful or not as a team that's implementing this integration work. We find organizations typically have 3 types of staff in them, and your sustainability will have everything to do in you understanding these different staff. There are champions. These are people that are gung-ho and will work hard on things, and sometimes they run off in a different direction. You got to kind of reel them back in, but they're typically people that will get things done. There's some folks that are resistant. They'll think of integration really as, that's something we tried before, or that's really not for me, or I don't like how it's rolling out. And typically those are folks that you have to get ahead of. You have to meet with them and find out what's making them speak that way and act that way. Sometimes they need to be moved along, but most of the time, these are just really smart people that have information you need. So resistant folks can typically be flipped into champions pretty quickly. And then most of the staff that you run into are going to just be confused, and they're going to need direction around what this all means for them. And that's why we really encourage the senior leadership and the integration team to have a communication plan for how you're going to roll this integration out. The communication plan could be one that's written down. We have examples of that if you're interested. Or it can just be something that you guys all agree that you're going to be doing on a regular basis, which is conveying the urgency of this integration work and making sure that all your terms are clear so everybody knows what integration is and isn't. They understand what population health management is. They understand all the different billing terms, whatever the terms might be, that it's really clear so nobody's confused. That your key performance targets for implementing integration are clear, both clinical and administrative targets around productivity on the administrative side and billing, but also clinical targets on the care pathway side around what changes should we see in our populations if we start doing this integration work. PHQ-9 should start getting better. Those scores should start improving. We should see referrals to treatment for people with substance use conditions and brief interventions, things like that. The communication plan also reinforces the importance of supporting staff who are leading the integration work so that they're not left out there trying to do this alone. Senior management really needs to have their back and always be messaging to all staff that this is very important and that we are going to do this integration work, and no, this isn't the flavor of the week. It's very important from the standpoint of the strategy of our organization. And finally, it really explains to staff, all staff, this is what we want you to start doing differently. This is what we want you to stop doing. And this is what we want you to keep doing but change a little bit. So just tweak some of these things in your workflow. Without a real communication plan, implementing something like integration or sustaining successful integration won't work. Organizations, the number one complaint staff have of organizations is communication is poor. And communication will never be perfect. That's why you have to constantly be delivering it, and constantly be talking amongst yourselves as senior leadership around whether you're doing a good job of it. I'm a big advocate of saying no message without a metric. So if you're going to message an organization that they have to do something different, you better be able to measure whether that metric actually, whether that message actually hit, actually took hold. And that's why things like population health management, that's why things like visiting teams and seeing if they're buying what you're selling as a senior leader really help you measure your message to see, yeah, this is actually taking hold in our organization. It's not good enough to just send an email and have an all-staff meeting. You really need to have a lot of communication with staff for a change like integration, because it's not a simple, quick change. I'm going to talk now. Any questions on communicating for effectiveness or change management before I move into our charters? Leah, if you can help me, I'll just look here. I don't see any questions popping up. So we talked about a couple steps that we've seen really effective organizations use to implement not just integration, but any change within their organization. The first is the communication piece, and making sure you understand that really well. But the first thing you write down, if you don't have a communication plan, is this charter or charge. And this clearly articulates the purpose of doing integration. This is essentially your business plan. And this comes from senior leadership. It clearly articulates the expectations for the organization around integration. It provides focus and urgency around priorities that the organization has and where integration fits into that priority. And it transfers ownership from leadership to the project team. Lastly, which is really important, it provides that project team with a sponsor. A sponsor is a senior leader at the C-suite level who's going to guide this project of implementing integrated health in your organization. Organizations that do this really well use that sponsor to monitor the implementation and to coach the team as they implement this new process or new systems change, which integration is. The charter components are written down, and they clearly state what the need is, like why are we doing integration. Not surprisingly, a lot of grants you write include these components because the grant funder requires it of you. This is essentially your business plan. So use the grant if you wrote one to kind of fill this in, but make sure that you're clear on what's the need for doing this integrated work? Why do this and why do it now? What's the scope of the project? What are the associated goals and outcomes you expect? What are the treat to target parameters? What are the administrative or financial back office metrics or goals that need to be achieved? And what timelines are we working within? The senior management doesn't need to get into the nitty-gritty of the work plan and like the specifics of what's going to be done when. They basically cast a very big goal, sometimes called a stretch goal, that's out there on the horizon. It's an 8 to 12-month goal that they put in that charter, and they say, this is where we need to be in 8 to 10 months. You guys go do it. We've prioritized this as part of the strategy for the organization and our success. Go do it. So this charter really clarifies that by defining the need, the scope, timelines, provides any access the staff might need. Certainly has to include resources associated with staff time. So certain staff are going to be working on this project for so many hours a week, and they're going to be doing it for a year or whatever it might be. That's definitely a resource. It provides risk of identification and contingencies, so anything that the senior management thinks that the staff might run into that are barriers. It assigns a staff lead or a champion and the senior leadership sponsor. And it provides procedures for any conflict resolution. The charter says, hey team, if you're floundering, talk to your sponsor. If you run into people that are resistant, talk to your sponsor. Leaving a work group champion with a work group charge and not giving them some fail-safes around what do I do if I hit barriers is really not good leadership. So it's important that the charter makes that clear. So an example of a charter I have here, and I have other examples if people are interested, would be this one where, you know, XYZ Healthcare has a strategic plan goal of implementing integrated health in the form of implementing the PHQ-9. And you can see here they clearly articulate by December 1st, 2017, XYZ Healthcare will have finalized standard operating procedures for screening, treating, and monitoring patients with depression and suicide. So it doesn't say how it's going to be done. It just says that it will be done. That's what a charter does. It defines the future state the organization is going to be in, and it gives a date, and it gives a defined deliverable. And in this one, it's standard operating procedures will be done. They will be approved and tested standard operating procedures. So essentially, December 1st, you can go live with implementing this, this new way of doing business. The charter provides those resources, so it clearly states, you know, we think it's going to cost this much. Here are these EMR reports you might need. We're going to give you some time estimates on which staff should be involved by how much, and you can negotiate those, but we've assigned this team to work on this project. It provides any risk contingencies, so if you know that JACO is going to be coming in December, or if you know that you've got another project around transportation redesign, like it's indicated here, that the leadership tells the team what is priority. And here they're clearly stating that JACO is priority. So if you get a JACO visit, that's priority. Or if we need to prepare for that, then you put this on back burner. But integration comes before this transportation redesign project we have going on. So if you're being pulled into that transportation redesign project, and it's going to get in the way of you achieving your work plan for integration, you're going to focus on integration first. We've approved you to not be diverted from integration because of this transportation design. So you can see this charter is really helpful for staff because we found in many organizations that the leadership just gives a bunch of priorities to staff, and they give it to the middle managers and say, hey, go do all this stuff. But they don't give it to them in a prioritized, rank-ordered way, which is the job of a leader. It's the job of senior leadership to rank order implementation of this integration work and tell staff where it fits and what to act on when. If they don't do that, we often see a lot of inertia, and a lot of these projects just get bogged down and never really achieve their full potential. So wrapping up the charter, it assigns the staff champion and provides that conflict resolution information, as I mentioned before. Once the charter is done, it's the job of the champion and the work group members that are assigned to do this integration work to develop that work plan. And again, many of you have got a work plan in your grant if you received a grant, but it's your job to make sure that the goal, which is the stretch goal, that by December 1st, 2017 for this organization, that they would have policy, they would have procedures in place essentially for the care pathway and the workflow around treating depression. That's kind of the big goal, and then you unpack it with those objectives, the different tasks or action steps, the different deliverables for each action step, the timelines for each action step, who's going to be doing it, and the resources required. So it's a very detailed document that has to be followed. It's a living document that changes every time the team meets because they have to update it, and they run into barriers. They might find new tasks they need to achieve. And this work plan kind of looks something like this. You've got the charter goal, which we talked about, and then you've got these 7 objectives that the work plan team put together. First, they're going to research best practice for treating depression. Second, they're going to assess their current state for treating depression and suicide to see what their base rate is. Then they're going to do a formal workflow analysis to see what part of their pathway and their workflow, both clinical and administrative, needs tweaking. They're going to tweak it. They're going to redesign it. They're going to test it, step 5. And then they're going to train staff in the delivery of this new way of doing things, these new procedures, because it's been tested to show it's effective. They're going to train staff in doing it. And they're going to make those supervisors responsible for ensuring that all staff implement this new way of doing things to specification of the procedures, of the protocols that were put in place. And then finally, they're going to implement that standard operating procedure. They're going to have a go-live date for it, which is December 1st in this case, so that depression care happens in a very standardized way starting December 1st as indicated by the charter goal. If you look at this here, the charter goal, step A, is the big stretch goal, and then the stretch goal is broken into objectives. And as we indicated here, they got 7 objectives for this work plan. So if we just look at one of those objectives, let's look, for example, at the first objective here. This first objective is research best practice for screening and monitoring depression and suicide. So the team is assigned to gather peer-reviewed documentation on depression and suicide screening, speak with maybe the AIM Center or other centers that are doing this kind of care really well to learn from them, identify all the billing codes and who can bill for what, protocols that are available for billing for this condition, and identify any current policies and protocols or procedures that are going to need to be changed as a result of implementing this new care pathway. So that's the action steps just for achieving that first objective, and they've got a timeline there of May 15th if we were talking about starting today in April, and they've assigned Bob to that, and resources that Bob needs is at least an hour a week for he and each member of the group that's going to be delivering on these action steps. So in that way, you can see that the work plan needs to be pretty detailed. It needs to be pretty clear, because if it isn't, you end up spending a lot of time and energy spinning your wheels, and the organization ends up burning through a lot of grant money and comes out the other end not ready to really implement, and it really puts you at risk as a business to do this well. So it's important that this work plan be looked at regularly, used, and that the correct allocation of time is given to the work plan. And I work with a lot of integrated health teams that say, gosh, we got to do this integration work. We hired a social worker and we got to get them into, the primary care clinic. It's just one of 10 things I have to do as a supervisor. I'm just going to do it, and they don't have a plan. And what ends up happening is they end up having to address crises that emerge, and their whole work plan turns into a crisis plan, which is not a way to create or sustain a good business. So if you don't have a lot of time, if you have staff that only have 15 minutes a week to spend implementing integration, that's fine. If they've got a good work plan that speaks to being able to spend 15 minutes of quality time that week, it will be much better implemented than a team that gives staff an hour a week and the staff don't go do it because they just get pulled in 12 different directions and they actually don't have any time, but nobody wanted to fess up to that. So that's why having senior leadership involved, making these work plans really clear, spending the time to get into this detail that I'm showing here has big payoffs from the standpoint of a business. This is really your business plan. These work plans aren't, nice quality improvement efforts. These are business plans. This is the same thing a restaurant owner would do if they opened a restaurant. They would have action steps and plans, and they'd be assigning people to do different things. For some reasons, I think sometimes we get into this thinking that, oh, this is just a nice extra thing we're doing. No, integration isn't a nice extra thing we're doing. The integration is part of your survivability as a healthcare provider, and if you do it well, you can, reap great benefits in the form of people getting better and also in being able to bill effectively and sustain your financial return on this investment. So the final, or one of the final steps here, once you get the work plan in place, this would be after December 1st when this team actually put that protocol in place, is sustaining that improvement. So you finally, XYZ Healthcare put this new PHQ-9 protocol in place and it's working well. You don't just walk away from it. You always want to be monitoring it using a plan, do, study, act cycle. And that's part of your population health management. If you remember, I said population health management includes clinical and financial data, and it also includes risk assessment. So with your PDSA cycle, you've got something in place. You want to constantly be looking at it and monitoring it to see if things are on specification, if things are in control. Because we know after new protocols have been put into a clinic, usually within 8 to 12 months, there's a disruption in those protocols where staff then tend to revert back to their old behaviors. It's just what human beings do. There's usually a deflection point after 8 to 12 months in our behaviors where we revert to old ways of doing things. The only way to prevent that from taking hold is to have a really good continuous quality improvement system that's monitoring this. And all staff need to own monitoring the continuous quality improvement process by watching themselves to make sure that they're following protocol as specified, by watching the data using population health management as a process. But really the person or persons that are most responsible for it are the supervisors. The supervisors have to make sure that staff work plans have built into them these policies and procedures around how their staff should be operating in their care pathway and workflows. And they have to make sure that staff are keeping on track with the behaviors they adopted when this new protocol was put in place and that they're not deviating from it. And if staff aren't deviating from it and people aren't getting better or you're losing money, it means that there's something inherently that needs to be fixed in the process. There's something inherently wrong in the process. And then again, you do a PDSA cycle around it. You get staff together and say, well, what do we need to tweak then? We've got all these bad bills coming back. Somebody's coding something wrong. Let's put a PDSA cycle on it. Let's put a plan together to see how to code things better. Let's put it into action and study it to see if it actually worked. And if it worked, then that's our new protocol, or that's our new part of a protocol for doing what we do. So this plan, do, study, act cycle is not only critical in the development of a new process by testing out a protocol, it's the same thing you use to keep that protocol within specification. So I want to talk a little bit and move into questions because we've got some time, I think, about sustainability and what it means for you all that are doing this integration work, because you're all in different places. I think some of you are about to go into doing this work. Some of you have been at it for a while with some grants. Some of you have been doing this for years, and you're kind of on this webinar just trying to see if there's anything new and exciting you want to learn. To recap, building on what Verna talked about over the last two webinars and what I've been talking about, sustainability really is about having great communication and urgency around that communication. So remember, no message without a metric. If you're going to change an organization and you're going to message that organization, you need to be able to measure whether that change took place or not. So for everything you ask your staff to do differently, make sure you have some way of measuring whether they actually did it or not. And this is where supervisors are so important. Use clinical registries and administrative dashboards for monitoring your targets. Population health management, as I've mentioned, includes both financial, administrative data, and clinical data. Use your electronic health record to look at the data and see if you're delivering on the model you put together. If your electronic health record can't create a registry that's robust enough to see all the aspects of your care pathways and all the aspects of your billing and your protocols to see if staff are actually following protocol, then you're going to have to build an Excel spreadsheet to work with your EMR until that gets up to speed. Do not let any process go unchecked. What you measure gets done. What you measured gets better. What you don't measure turns into chaos and crisis. Have a go live date for implementing any new integrated health protocol. So if you find a new way to bill, if you find a new way on, like the PHQ-9, you're putting that into place, there has to be a clear demarcation point between, hey, we're developing it, and we have a work plan and a team working on it, and, oh, it's done, this is go live. If you'll remember, when you've had an EMR go live, they don't like roll it out clinician by clinician, right? They do go live, like June 1st, we are now using the new record. Same thing with protocols. June 1st, new protocol. Your supervisor is going to be training you on it because we trained your supervisor, and you will be delivering on this new way of doing business. We will not do the old way anymore. Make sure your supervisors are accountable for hitting all of your clinical and administrative targets as it relates to doing this work. They're really the ones that have both the hardest job but the most important job. They're the ones you really need to be supporting from the senior leadership position to make sure this gets done. Revenue cycle, Verna talked a lot about this. Know your billing, know who can bill for what, and make sure people are billing appropriately. Know what you can't bill for and where you're going to lose money so that you can create cost offsets where other people can bill at a higher rate, or your person who can't bill is making that person who can bill so efficient that the person who can bill is paying for that person who can't. And this is where we see, the medical assistants, the front desk staff, peers, really critical staff. They have to be highly efficient in making the billers, the people who can bill, very effective. Credentialing delays, I think Verna talked about this. Make sure you are very aggressive with your credentialing. If you have staff that are uncredentialed, they are going to be a burden on your financial income for your organization. So make sure that you understand credentialing clearly and that you're very aggressive with the credentialer to remind them of the date they said that they would get back to you on this person being credentialed. And if that date passes, then send them an email saying, we are considering this staff credentialed because you said it would be to us by this date, and we're going to start billing. I think Verna probably also talked about, if you're a big enough organization, see if you can be your own credentialer. Some payers will allow organizations to self-credential. They monitor the credentialing, but it allows you to do your own due diligence around credentialing your staff. Be very aggressive with funders, both grant funders and payers. If you're implementing this integrated health program, make it really good. Make it a really appealing program to your funders, meaning find out what makes your funders stay up at night. Is it HEDIS scores? Is it, all-cause admission scores? Is it hitting costs? Design your program to meet what their needs are. Go to them and say, hey, we're going to meet your needs. We need these rates. Negotiate a rate that's going to be both effective for you and efficient for you to be able to stay in business, but also meaningful to your funders. And this sometimes can take years to develop relationships where you can negotiate pilot projects where you say, hey, for 6 months, we're going to start treating, people who have X condition, and we're going to cost it out. And after 6 months, if we hit our targets with this condition, could you give us a rate for it, or an enhanced rate if you already have a rate? So be very entrepreneurial. This is the time to really get entrepreneurial in your approach to delivering healthcare, because we've adopted this system in the United States of capitalism, and then we have a capitalistic way of doing healthcare. Take advantage of that. Use it to your advantage as a healthcare provider. I'll do this quickly, then I just want to take some questions. Sometimes I work with organizations that say, we don't know why our implementation failed. We can't sustain it. And if you look at this graphic, it looks a little busy, but I'll start with the top. Just bear with me. So that top left light green box speaks to the absence of urgency. If you look just below that box, there's urgency there. So each of these lines from left to right is a pathway towards sustainable change in your organization. If you are missing any of these components, as indicated by the light green box, like on the top one, if you have no urgency for change, what ends up happening is you get a slow start on the right-hand side there. That's the outcome. You get a slow start that eventually just grinds to a halt. You go back to doing your old ways of doing things. If the second line down, if you have no guiding team and vision, if you don't have senior management and a work team with champions on it really driving this change, you get a fast start because somebody is excited about it, there's urgency, but it never really goes anywhere because nothing was ever fully implemented with thoroughness. On the third line down, if you don't have a capacity as an organization to change, if you don't have senior management that are dedicated and use a change management technology like I talked about, what you end up getting is a lot of just sheer anxiety and frustration in the organization because frankly, the middle managers and the frontline staff feel like they're just being given a lot of work to do, a lot of unfunded mandates or a lot of unresourced mandates, and there's no real way to create effective, prioritized change within the organization. And you get a lot of staff burnout. And then finally, if you don't have, the short-term wins, those little things you're able to do and then message the hell out of them and say, look how we did it. We researched PHQ-9s and we know how to do it. We're going to next move to putting it in place. You get a lot of haphazard efforts and false starts. You get a lot of burnout there too. You really need to be able to communicate and show that the organization is making strides in the direction of achieving its vision and mission and actually executing this work plan that you've put together for yourselves. So with that, let's take some questions. If anybody's got them.
So as a reminder, if anyone has questions, you're welcome to either raise your hand right next to your name, or you can type in your question via the question and answer box, and we'd be happy to take it either way.
And again, you can have questions about any of the, oh, I was just going to say, yeah, any questions about my presentation or anything to do with, sustainability, the business aspects. Were you going to open someone's line, Leah?
No, I was just going to say we can give people a few minutes to type.
We'll leave them with some uncomfortable silence, hopefully generate some questions. No questions, anybody? I can't imagine that I hit everything that you guys came up looking to hear, came to this presentation looking to hear. I will say that we do have some resources associated with these presentations. We're going to have a billing cheat sheet coming out. And as I mentioned, I've got sample communication plans, sample charters, sample work plans. If you are interested, please let me know. Or let Joan know, or Verna. And if you don't have questions, if you've got comments of examples where you guys have been able to pull this off, if you are one of these organizations that's doing this really well, we'd love to hear about what you've done, what's been effective, and kind of do a little bit of bragging. I see, Sue, you have your hand up. Let's see if we can open your line. Go ahead, Sue. Thank you, Sue.
Yeah, we're in the process of, we have a grant and we're doing a planning grant. So we're doing a lot of, the protocols, trying to figure out, how we want to use something like the PQH9. But we have multiple organizations involved because we're rural. So most of what you talked about was within an organization. How would you envision coordinating all this between individual counselors in the community plus 3 or 4 other organizations? So would you see a team in each of those organizations, or how?
Yeah, that's a great question. What we've seen be most effective with multiple organizations is you have to first make sure the leadership of all the organizations has a shared vision for what this is going to look like. And again, it's a high-level vision. It could be something as simple as we're going to do effective integrated health, and all of our organizations agree to screen for depression. Simple as that. By a certain date, we're going to all have protocols for screening for depression. It's not even saying which instrument they need to use sometimes, but we all know they usually go with the PHQ-9. So have a leader approve this so everybody's on the same page, so if things go sour, leaders can talk to each other. And then it makes sense to have the leader, the champions, they're going to be implementing work plans at each site, come together and develop just a very high-level work plan with some timelines around what everybody thinks is realistic for them, for each site to be able to implement a plan to achieve that charter or that charge that the senior leadership across those organizations gave to them. And then each site is going to have to develop their own work plan because each site's different, and it's got different staffing and different, even room design can affect, how you do PHQ-9s and EMRs and all that stuff. But each site is going to have to at least agree to some minimum standards around how you're going to share those data between each other to do the care coordination piece. So when you get that kind of multi-site rollout of an integrated approach, it can take a little longer, and you do kind of have to really ramp up your communication across sites, and at least for the first 3 to 4 months, meet very regularly across sites until things get in motion and you can get rolling forward. But that's how we've seen that be effective. Does that make sense?
It does. I'm kind of confused between what we're doing. I mean, I think we're doing that in our planning process, but then when you get into implementation, it strikes me that you would have to continue to get together and meet and talk.
Yeah, because you're going to have deliverables at the system level, right? We're all agreeing we're doing PHQ-9. We're all agreeing we're care coordinating, whatever that's going to look like, whether you're going to be sharing emails, secure email, or actual, linking of records or sharing Excel spreadsheets, whatever, that you're all going to have some, it's always helpful if you have kind of the same measures being used across sites. So if you're all agreeing the PHQ-9. So there's going to be like a high-level charge for all the sites from the leadership. Then there's going to be a high-level work plan, and then there's going to be drill-down work plans at each site that speak to what that site's going to do. And then at each site, they're probably going to come up at different times because each site's going to be different, which is fine. So the sites that are out ahead of the other sites can kind of be the champions and teach the other sites what worked for them. So you can do kind of a learning community kind of approach to it. But it takes a lot of meeting, it takes a lot of phone calls, it takes a lot of holding each other accountable and setting up deadlines and saying, on this date, we said we were all going to be here, you're not, what can we do to support you? And not being mean to people, but everybody, it's that urgency piece that was probably the biggest thing that came out of Cotter's research, was the ability of urgency to create change, effective urgency. You don't want to create urgency that pisses people off or creates anxiety. You want to create urgency that's challenging, that makes people kind of get excited. And that's a hard thing to do, but it's worth continuing to try to do. And that's why leadership has to be involved when things start to slow down. They have to be able to step up and say, hey guys, this was the charge, how are we doing? That's a great question.
Thanks. Great.
Anyone else?
Well, oh yeah.
I don't see anybody else. I don't see any questions. Are we at the top of the hour?
Yes, we are. So
okay.
Great time to end. So thank you, Jeff, and thank you everyone for attending today's webinar. Once you leave today's webinar, you will receive an evaluation survey on the screen, and we'd appreciate if you complete it to provide your feedback. You will also receive a follow-up email by the end of the week with a link in the slides for the recording of today's webinar. Thank you again for joining us, and please enjoy the rest of your day.